When did you start your practice?
Basically 4 years ago. And before that, my co-owner, business partner, that's a nurse practitioner, he and I started a different health optimization preventive medicine clinic. And we worked there for 1 year. And then I worked at College Park for a little over a year as well, kind of part-time at both. And then I just took the good of both of those clinics and then made Gillett Health.
After you graduated KU Med, then you went to College Park, did the whole traditional medicine route.
Yeah, and first I went to residency, and then after residency, I worked maybe half time at College Park for a little over a year. So it really wasn't that long. You know, I always thought that I wanted to work at College Park, and Dad worked there for more than 30 years. But with the changes in basically the management of College Park, the practice itself was owned by HCA, which is this massive hospital.
Yep.
I just couldn't provide the same quality of care for patients as I can outside the system. And candidly, I get a lot of people that, disparage people who go outside the system. There's this false dichotomy of people who think the only physicians that practice evidence-based medicine work at academic centers and large hospitals.
Yeah.
And they work for the, basically just 5-minute visits for insurance companies that are just following an algorithm. AI is going to take all of those people's jobs, by the way. Mm-hmm. And then they see people who do functional medicine or hormones as people who don't practice evidence-based medicine, which is true 98% of the time. But just like in any other business, you have to vet the wheat from the chaff.
So would you say that was the main reason you wanted to branch out, because you wanted to spend more time with your patient?
Yeah, my hands were also sort of tied because I was doing visits that were often an hour long, and you can't provide for your family getting paid $30 for an hour-long visit. Primary care providers are paid worse than ever. Compensation has actually not increased for physicians, despite billing and premiums going up, almost doubling in the last 10 years. I mean, if you look at the two graphs together, it's crazy. If you're a specialist, it's not as bad. And I guess technically I'm a specialist because I got my obesity medicine board certification. But for that one, generally, it's not a procedural based thing. So, you're either a robot on the assembly line of the insurance model, or you're a cookie cutter robot on the assembly line of some big functional company. There's big pharma, and a lot of pharmaceutical companies own pharmacy benefits managers, which are basically a middleman that steals from everyone. Legally, they actually have an exception to what's called STAR clause, which are anti-kickback clause. So, you can't get anything more than a lunch. And if you look up my license number, then you can see how many dollars worth of lunches I've accepted from companies. But at the same time, it's actually completely blinded and a secret how much money that's bribe money. I mean, how much kickback money that pharmaceutical companies and insurance companies pay PBMs, this middleman, in order to be the preferred drug on their formulary.
I hate that about our healthcare. As soon as I found out about this, it really was disappointing, because it's just a business. Mm-hmm. And we're dealing with people's lives and their health. And I think now it's really been exposed with RFK coming in, and even what you just said with the middleman. I didn't know about these people until recently because it's now in the news. And it's just unfortunate because, again, we're talking about life and death with some of these people. And I think a lot of them, correct me if I'm wrong, are, for example, getting procedures they don't even need, or medicine they don't need because somebody else wants to make money.
Yeah, if you look at people getting care from a dermatologist, about half the time you'll get a procedure. And a lot of times it is just being safe, but a lot of times it's because the compensation is higher for a procedure. And it's not unique to that specialty. That specialty is actually one of the least affected ones. But it's no different if you go to a cash pay clinic. If you go to a functional medicine clinic, you're going to get a huge stack of supplements that you very likely don't need, partly just because the provider doesn't know. So I guess this is a hot take. right? But it's just two sides of the same coin. It's like Walmart. You go to a hormone clinic and you get TRT. You go to a med spa and you get your GLP-1 Ozempic.
Yes.
You probably don't even need that.
Right. It's like you signed up for it just by entering in the doors of the place.
Yep.
So what's the difference between, maybe first off, what am I missing here? So we have the traditional route, the Western medicine, right? Homeopathic and then functional. What am I missing?
Yeah, so, it's kind of a false dichotomy. Traditional medicine and functional medicine should not be two different ways of thinking. I've heard people say, well, I have to turn off my conventional medical brain to think functionally. And for me, it's the opposite. What functional medicine is supposed to be is just good root cause medicine. You're finding the root cause of an issue and addressing it. And sometimes people actually don't want this because when you dig really deep, you'll find stuff that can harm you. For example, people going to these lab companies, these functional medicine lab companies, they test things like Lyme disease tests and heavy metal tests and tick-borne illness tests. And I, of course, have patients that have all of these pathologies. But if you have very low pretest probability of having these, you're very likely to get a false positive. And then it leads to months of harm because you're suffering and anxious and stressed about it until you finally come to a provider like myself, who, of course, is happy to see them and either rule out or rule in. But it's much easier if you give the patient the risks and benefits of the test before they order it, rather than just let them go to a website and click a button because an influencer doctor who never finished residency and is not board certified told them to.
What are your thoughts on full body MRIs? Because those are becoming popular.
Yeah, pretty similar. So I do order them for the right patient, but when you do a full body MRI, you will find something. So I think this is a test that you should discuss this with a physician before you order it. Some people have very high risk thresholds and they're okay with a high level of stress. So mental stress is not that difficult from physical stress. If you have somebody that is a newbie in the gym and you put them under a 500-pound bench press, it's going to crush them. Now, there's some people who can come in, they're veterans, and they can handle a extreme weight like that. And if you find what we call incidentaloma, which is just an incidental finding that might be a tumor and it might not be a tumor. And there's other types of incidentalomas too. But you have to have someone who is a veteran with health information or a veteran with taking on that mental stress. So some people can adapt to it, but I'm not a fan of the MRI companies that let you order, an AI-read MRI for $500, and it's full body, and it's usually not even high resolution. So MRI is done in what's called Teslas, and you want an MRI that's at least 3.0 Teslas because it's a higher resolution. You have less false findings, both negatives and positives. And you ideally want a radiologist to actually discuss these things with. So there's local radiology groups in Kansas City that we partner with that will order a good full body MRI. The radiologist discusses in person the findings with the patient, and then we also discuss the findings with the patient.
When did you know that you wanted to become a doctor?
I was probably 12 or 13. I figured, College Park is faith-based, and I'm a Christian. I always say that straight up on whatever podcast I come in because I think spiritual health is very important. But I figured I'd just work at College Park and, either take over their functional medicine clinic, which I did for a year, but then everybody left because it's not compensated well, and we basically couldn't do anything that we wanted to do. But yeah, I figured that I'd probably work there for 3 decades like Dad did, but it was just set up to where it was impossible to do so. And also, frankly, I got a lot of negative feedback from the other providers there. I was very disappointed in them because they were not lifelong learners and they were not open-minded to the areas of non-conventional medicine that are right.
Right. Which is interesting because you'd think once you become a doctor that, you'd think you're science-based. Science doesn't just stand still, right? It's continuing to evolve. We start to find out more and more and more things. Specifically, even an example would be the importance of metabolic health, right? But then it seems like a lot of doctors they stay stuck in time, and they don't keep learning about what's the best way to treat their patient.
It is science-based, but the science that it's based on is expert guideline. So expert recommendation is supposed to be at the bottom of the pyramid of evidence-based medicine, but this is what most people follow. So if you're a urologist, then you're usually going to go by the AUA guidelines, and you have exceptions like Dr. Fantas, who's a local urologist that helps write the guidelines. But if you're helping write the guidelines and changing them, you're obviously not going by the guidelines. You see what's wrong, but your average medical doctor is not going to see what's wrong with a guideline.
When did you become a Christian?
Probably 7, 8, pretty hard to remember, actually. I've always thought for people who are very analytical, some physicians, but more so scientists and PhDs, it is much easier to become a Christian earlier in life.
Why is that?
I was very fortunate.
Elaborate on that. Why do you feel that way?
Yeah, so I don't know how far you've down the rabbit hole of like different ways that people prove their faith. Some people prove it very emotionally. For example, before they were a Christian, they struggled with lust and immorality and sexual sin and this and that. And then after they become a Christian, they knew it was real because they were able to conquer that.
Yes.
Or like substances, could be anything. Like
this is probably the most common.
It's different for everyone, but I consider that and that's a perfectly fine way, but that's a relatively emotional or mental proof. But some people get into textualism, or they get into like these various almost scientific disciplines of looking at, a Hebrew text versus other texts. I would say Wesley Huff, who's making the podcast rounds, he would definitely be in this intellectual category. Most apologists are kind of in this category as well, which is for people who don't know, an apologist is basically just someone who tries to logical rationale using critical thinking of basically why Jesus is God. I'd sum it up. But yeah, when you're a child, regardless of your tendencies, none of those things, they are a lower barrier to jump over. So that's why I think in the Bible, it very accurately states it's much easier to have a childlike faith. I think that's what it means. It's just a lower barrier faith-wise.
So you came to your faith analytically at 7?
No, not analytically. No. Okay. Like any other 7-year-old would be, and then you cultivate it through sanctification, and then whatever else makes it real to you.
So when was that moment where you said, my analysis has come to the conclusion that Christ existed and he is God? Yeah,
I don't think anybody fully makes that scientific analysis 100%. Okay. So I think that's why everyone still requires some faith.
Yes. Yeah. For me, I went through that same kind of thought process. To me, it's simple. How did the universe come into existence? From what? What was the starting point? And obviously, it can't be from nothing. There's no way, I don't think. And then
requires a lot of faith.
That's right. You got to have more faith for that. Right. But then we start narrowing down. We zoom in on Christ. First is, did he exist or not? And I think we can all agree that. You'd have to have.
Simple.
Yeah, that's pretty simple. But then we start looking at other things, such as him resurrecting the hundreds of people, many people that witnessed it, but more importantly, died for this. You don't die for a lie, right? If you're lying about something, you're not going to die for it. So for me, it's almost like I could never let that go. I could never just overlook that. But anyways, thanks for sharing your faith. That's very insightful. So I have 1,000 questions. I'm going to try to get as much through this as possible. Would you say your specialty is hormone, like hormonal?
That's probably what I'm most well known for, and a large portion of our patients and clientele are seeking care for fertility or hormonal pathologies or body composition.
So let's start with what exactly is TRT, which is testosterone replacement therapy, and how does it work?
Yeah, so TRT is testosterone replacement, which in general can be any sort of testosterone or other androgen, and it is replacing the androgen that you naturally produce in most cases. Actually, not in all cases. So in some cases, it's just testosterone therapy. For example, there's a type of pill that you take that's absorbed through your lymph system that usually does not shut down your natural production as significantly. And there's even nasal gel that you can take where you have most of your testosterone is still produced naturally. So there's always exceptions, but you think of your kind of classic cookie cutter TRT as 200 mgs of testosterone cypionate, which is testosterone bound to a chain called an ester that the body cleaves that chain off. It's activated, and you inject it usually with an estrogen blocker every week or two. But the problem with this is that's not what's actually studied. What's generally studied, there was this massive study in the New England Journal of Medicine about the safety of TRT in high-risk individuals. That was done with androgel, which is a type of topical gel that's slow release, different than cream, to complicate things even more. And
because it's injection or topical, right?
Yeah, there's a big difference in the doses and whatnot. But that's what it is, and everyone has androgens, males, females, everyone does. Levels are actually usually pretty high in total androgens during pregnancy, but there's a protein that protects the babies, particularly female fetuses, from masculinization. And then second puberty is in the first 3 months or so. Very young infants have very high levels of hormones, either male hormones or female hormones, depending on their gender. And then third puberty is adrenarche, where the adrenals make a lot of hormones. So the adrenals make a lot of testosterone. Many females that have PCOS or too high of testosterone, it's actually made from the adrenal and not the gonad, which is the ovary.
It seems like a lot of, for example, females are entering puberty earlier. Is that the case? And if so, why?
Yeah, there's actually multiple reasons for this. The most common case is just high insulin. So obesity, insulin resistance,
we'll get into
metabolic syndrome.
Okay.
Yeah, so that certainly contributes.
So it's not the hormones in the milk? Is it the hormones in the milk?
Mostly not.
Okay.
Yeah, there is other reasons. And, if someone drinks 3 quarts of soy milk per day, then that is enough genesetin, which is a phytoestrogen, in order to be clinically significant. So there is other things that contribute.
TRT prescriptions in the U.S. jumped from about 7 million to over 11 million in just 5 years. What do you think is fueling that surge? And is it a good thing?
Yeah, I think it's good. I think it's mostly because of podcasts. Joe Rogan talks about the TRT he's on. Many big podcasters do. But I think that the other reason behind that is a generational shift. So I think that people in Gen X or even millennials care more about their testosterone and body composition, how they're going to age, because we see the previous generation and how even many people who had relatively healthy habits and on average higher testosterone than people in my generation, we see their debility of age really kick in, and they're not able to do the things that they'd want to do, like play with their grandkids or great-grandkids and continue to go on fishing trips and hikes and play tennis and this and that. And I think that they see TRT as a tool to get them there. That's obviously not always the case, but for prescribed testosterone, I would say it usually is. For people who are getting unprescribed testosterone at their gym, which is a lot of people.
I know somebody who's doing that. He already did that. He doesn't do it anymore.
There's a lot of people. Yeah, I mean, talking with my friend, Dr. Fantis, who's a excellent urologist, and he works at KU, but he and I estimate that between 30 and 50% of all adult males have tried some sort of testosterone therapy. It could be supplements at GNC that their football coach gave them or their wrestling coach, because those used to have prohormones in them, which is basically forms of testosterone.
You could get them over the counter?
Yeah.
I didn't know that.
Yeah, most football players used to be on, one of them was Superdrol, and then there was a methandrostenolone and methyltrenolone. So there's several. I can't remember all of them off the top of my head, but 10 or 15 years ago, a lot of people did prohormones. A lot of people just do Clomid or enclomiphene, because a lot of family doctors prescribe that. If someone comes in, they ask for testosterone, and they say, well, no, don't do that because they just make up a reason. They usually say it's not heart safe. And then they say, but instead, here's a pill that you can take that'll increase it. So it increases the number. They don't feel much better, but the number went up. But yeah, I'd say at least a third of adult males have tried something in that regard.
At what point should someone consider starting TRT, and what signs or lab markers do you look for before recommending it?
When the total benefits outweigh the risks. And some of the main benefits are it gives you the tools to be more active, better exercise, better sleep in some cases, worse sleep apnea in some cases. And then it also does things like helps prevent diabetes, and it can improve mental health, depression, libido, lots of these various things. But yeah, you just weigh up all the total benefits, and when they outweigh the detriments, you come to a decision together with the patient if it is right for them. That being said, you want to get at least 2, ideally more, morning testosterone levels. Does not matter as much if you're fasted, actually. And you want to get a fasting insulin, because that's the most common cause of low total testosterone in men.
Nobody talks about that. They just say, look, check your T, and then, go off of that. But I mean, even I've heard of people doing this, and they don't even check their fasting insulin.
Yeah. It's commonly missed. You could have a normal A1C and your fasting insulin can be high.
Yeah.
And you, of course, need LH and FSH to see if it's basically the gonad not working or the brain not sending the signals, and a prolactin, which is another relatively common cause. Not a lab marker, but if you have other signs and symptoms of sleep apnea, like waking up a lot at night, gasping for breath, if someone witnesses you stop breathing at night, or if you feel like you have to nap a lot, or if you have a high red blood cell count, then you should also be checked for sleep apnea. That's probably number 2 reason of low testosterone.
Because they're not getting enough sleep.
Yeah, they could be
quality sleep.
Yeah, and some people, this is the tricky part, they're hypopnic often, and they're apneic only a little bit. So they feel like they're sleeping like a rock, because they go to bed at 10 p.m. and wake up at 6 a.m., and they don't notice that they're waking up at night. But their apneic-hypopnic index, which is basically how they're breathing not enough at night, is making the quality of their sleep so poor that they're producing less testosterone.
So when you're checking for the biomarkers, just specifically testosterone, you have your testosterone, then your free testosterone, and then the other one is the SH, is that right? Mm-hmm. So then what should the numbers be for a healthy male in general?
Yeah, in general, a total testosterone over 500. And there's always exceptions, of course. You want a free testosterone over about 12 for general purpose. Mm-hmm. Athletes, both from a body composition and an athleticism standpoint, are going to do better with a free testosterone over 15. Just keep in mind that most free testosterone lab assays, which is just the type of lab test that it is not super accurate. So most people are better off if you have a total testosterone and a SHBG, which is that protein that binds it up. Just go to MedCalc or just Google or ChatGPT. Just put those numbers in, have it calculate your free testosterone, and that's usually more accurate.
And then what should your SGBG, is that right? Mm-hmm. What should that be?
In general, the higher the better.
Really?
As long as your free testosterone is okay.
I thought it was supposed to be the lower the better.
The lower it is, the higher your free testosterone. So that's the big caveat.
Right.
But I would rather have an SHBG of 100 and a total testosterone of 1200 than an SHBG of, 15 and a total testosterone of 400.
So you're really looking at the ratio between those two numbers.
Yes.
It needs to go up. If one goes up, the other one needs to go up.
Yeah. So if free testosterone remains the same, you want a higher and higher SHBG. So your total testosterone is just going to go higher and higher and higher. Now, most males don't want a SHBG over about 100.
Okay.
Because other issues arrive. It also binds up estrogen, actually. And it's difficult to metabolize hormones at a normal rate if your SHBG is very high. But yeah, I don't think SHBG is the enemy. I think a lot of times when it's low, it's just because people are insulin resistant, or they have metabolic syndrome and obesity, or they're taking things like SARMs, which are supplements that people get over the counter that Gen Z is taking.
SARMs?
Yeah,
What is
actually
that?
super popular in martial arts.
What is that?
They're selective androgen receptor modulators. So if you've heard of S4, which is androgen, or ostarine, or LGD, which is ligandrol, or RAD140, there's a whole bunch of these different selective androgen receptor modulators. They bind the receptor that testosterone does in your muscle and your bone, but they block it in some other tissues. So it doesn't necessarily feel like testosterone, but it gives you the same performance-enhancing boost. And it's an oral supplement or powder that is sold as a research chemical. So it's used very frequently. In fact, a well-known Olympic athlete, I think a medalist Olympic athlete from the United States, popped positive for one of these supplements, but it turned out he was not taking it, so they gave him an exception, and anonymous person, so we don't know who it was. It's a male. But he got it because he shared lifting sleeves with his bodybuilder friend who was openly taking this. So his bodybuilder friend sweated out this supplement. It got into his knee sleeves, and then I guess they switched it because they were sharing it for squats, supposedly. I mean, it must have been true. He got the exception.
Yeah.
And then it absorbed so much through his knee sleeve that they detected it in his blood. And
Oh my goodness. What's the downside of taking this supplement?
Similar downsides to other synthetic hormone replacement therapies. So there's certainly benefits. It's being studied in combination with Ozempic, which is semaglutide. And the data looks really good in 70 and 80-year-olds is who they're studying it for. And data also looks very good for prostate cancer, breast cancer, because it's not going to grow prostate cancer. So a lot of people have less muscle wasting. They have better quality of life. Their activities of daily living, they maintain those. They can still climb stairs afterward. So it's not, just like any other molecule that we have been given, there's upsides and downsides to all of it.
So what about for females?
Yeah. So females, I would argue it's even more important. And, just statistically, most of my patients tend to be females because at some point in their life, 100% of females will go through menopause.
No.
And I think, people are actually better off monitoring their hormones at very latest during perimenopause.
What is that? Just like right before it?
Yeah, before it, or it could be 10 years before it. So, I would say if average menopause is very early 50s, starting at age 40 at the latest is what I would do. And I would get a mid-cycle lab. So you look at your estrogen and your testosterone in the middle of your cycle, or a later cycle lab called luteal phase, maybe day 21, 22, 23. And you can look at your estrogen, androgen, and progestogen. And there's a whole bunch of other things that you can do as well. But it's important to keep in mind that no one regimen works for females, even more so than males. There's just more variation. There's 10 times as much variation in normal testosterone levels, whereas males, there's only 3 times as much. And what we end up seeing is females, and usually males too, they just start whatever regimen their OB-GYN has personally taken that has worked for her.
Without looking at the biomarkers.
That's what I see.
That's
especially locally.
Oh,
a lot of people don't
goodness.
even have any labs checked at all before starting. They just talk to their nurse practitioner or OB-GYN or whoever else, and they say, you know what, when I went through menopause or when I turned 50 as a male, I was low energy and I started this and I've been taking it since and I feel fantastic. And I'm going to prescribe you the exact same thing. And this is a little bit of a straw man argument for it. But honestly, there's a lot of truth to that. So you got to individualize a regimen. About 50% of females benefit from an androgen more than the downside. But most women who take testosterone usually end up having more downsides that they don't even realize.
Is there a preferred delivery method?
In general, I prefer subcutaneous androgen for females.
So injection?
Pellets I'm more of a fan of in animals than humans.
Yes, they're putting pellets in their back?
In their glute and kind of in their butt.
Wow.
Yeah, I mean, you can technically put it anywhere.
As opposed to injecting yourself, weekly? Isn't that?
Yeah. Generally, for some females can even get by with once every 2 weeks.
But
usually once a week, sometimes twice a week. It actually depends on SHBG, just like it does in males. And you can also inject estrogen. You can take estrogen patches. You can take estrogen creams. There's all sorts of things.
But you prefer injection?
For androgen, I do. For estrogen, there's a lot more flexibility.
So kind of reversing back out of all of the details we just discussed, why are hormones like important to really measure and really look at?
Yeah, they're just the literal signaling molecules that convey every signal throughout our entire body. So, I mean, they're every bit as important as looking at your gauges when you drive a car. Yeah, I mean, if you look at women who are treated, even in the Women's Health Initiative, which was kind of a study that a lot of people took women off hormones because they were using non-bioidentical hormones, they were using equine hormones. Generally, your all-cause mortality is going to improve. It's not going to get worse. But the lower your levels are, the more you're helped. So, for someone that's menopausal and let's say they're that average American, they're somewhat obese, they have a lot of adipose tissue that's aromatizing the adrenal androgens into estrogen, then they might not feel as good as someone who has very low estrogen levels in menopause. But, you should address the root cause. Instead of saying, well, you're not necessarily a good candidate for hormone therapy, you should decrease their body fat via a multidisciplinary approach, including lifestyle medicine, and then reassess.
Because when you say adipose, that's fat.
Yeah.
Right.
So that, the average American is overweight or obese.
Yeah. Is it ever too early or too late to do TRT?
It's never too early and also never too late. However, the younger you are, the more likely you are to have downsides of temporarily decreasing your sperm count. So, temporarily impaired fertility is certainly a downside. And then, the other downside is whatever is causing it to be low is much easier to be fixed when you're in your 20s and even in your 30s than it is when you're, say, 70 or 80. And there's obviously a big gray zone in between. But I think everyone, almost regardless of age, but certainly if you're in your 20s and 30s, I would be a lot more aggressive with this, especially if I was in that patient's shoe. Try everything that you can to naturally improve your hormone levels and your hormone balance. And then, if it's still not improved, and maybe you know why, then sure, a replacement is reasonable, and you can do it temporarily and regain what you've gotten. But it's also never too late. Just keep in mind that your risk of things like AFib or fast heart rates or abnormal rhythms tend to increase as age goes on as well. But the upside also increases. So some of the craziest responses you see are people that are in their 60s.
Once you get on it, can you get off of it, or do you have to stay on it forever?
Nobody has to stay on forever. The caveat is you'll go back to what you were at before.
So if you want to thrive, you got to stay on it, at least at those levels that you
depending on how low you were before. If your previous level is 400 and you tried nothing to naturally improve it, and you're 35 years old, then if you improve your lifestyle, your diet's better, your exercise is better, your sleep is way better, your kids get older or something, then yeah, you can pretty easily get off of it. And maybe you get to 800, maybe you get to 600, or maybe you just go back to your 400 and that was actually your maximum. That's another reason why I like to optimize naturally as much as possible. That way we know what you can get back to if you choose to come off.
So as a 42-year-old male, what should mine be at for an optimal level? Like, I'm good.
Yeah, certainly over 500. So you're obviously not overweight or obese. SHBG is largely genetically determined. We could check it and it could be 15 and it could also be 100, and neither would surprise me. But, if it's 100, then a total testosterone of 500, if anything, would be a little low. You'd probably want 600 plus. And then if your SHBG is 15, I'd be shocked if your total testosterone was 500, just because it's going to get metabolized so fast. I would guess it's somewhere between, even 300 or 400. People who are very, very lean. So, if you have the people who have to like cut down for a weight class or this or that.
Yep.
I don't know if you've seen people check their testosterone. Actually, a lot of people in martial arts have done this. I know my friend Derek, who has the More Plates, More Dates channel. He does this for fighters sometimes. And same thing for bodybuilders, actually, natural bodybuilders. And I don't know if I've ever seen a natural bodybuilder or martial artist that has a normal testosterone right before a event.
A match, yeah.
It's almost always low.
Really? Mm-hmm. Why is that?
If
Cutting?
you're lean. Heavyweights is not as much of a thing because they're not like cutting down to be as shredded as humanly possible. But people that go into these huge deficits, even UFC fighters, your body detects that you're in a caloric deficit and it basically goes into starvation mode, and you're not going to prioritize making extra testosterone.
Which then can really open up a whole nother conversation with fasting, but we can save that for later. Mine was, total was 834, free was 99, and then SHBG was 70.
Yeah.
Is that ideal?
Yeah, not particularly surprising. I would say 800's certainly ideal. A free of 99 picograms per mil, that's the same thing as basically 10 nanograms per deciliter. If that's accurate, your free androgen index could be a little better, your free T. So, your SHBG being high, I would see as a good thing. But if it was a little bit lower, you'd probably have a bit more athleticism. And I don't know if you checked it when you were younger.
I need that.
If you checked it when like 10 years ago, I bet your SHBG would probably be 40 and your total T was still probably 800s to 900s.
Yeah, it sucks getting old. It does. What about, all right, here's one because I've heard a lot about this one. How important is the cortisol to DHEAS ratio?
Yeah, it's relatively important, but it's most important for postmenopausal women.
Oh.
Because DHEA sulfate is just another androgen. You have plenty of testosterone to where it's literally just a drop in the bucket. To where if you have almost no testosterone otherwise, DHEA can backfill that to some degree. And it also tells you about if your adrenal, at least at that moment in time, if you got these in the morning and then repeated it at 6 p.m., your DHEA sulfate to cortisol would be completely different. Your cortisol would be much lower. So it can change quite a bit. But yeah, it's relatively important. It's mostly important in the context of chronically elevated cortisol to DHEA sulfate ratios, making an athlete higher risk of injury. So this is often studied in the military.
That's interesting. Do symptoms matter more than the numbers?
Generally, yes.
Because it really comes down to how do you feel, which is really this whole, that's the whole journey. Why are we even talking about this? Is so we can feel better.
The numbers help you tell if the symptoms might be coming from something other than testosterone. So with a high total testosterone, it seems unlikely you would have a lot of mental or cognitive symptoms related to testosterone. But with a free testosterone of around 10, especially that you're used to a free testosterone of probably 15 plus or even 20 plus, or maybe even 30 plus 15 or 20 years ago, then people do start to notice body composition changes and changes in their athletic performance. So that's why a lot of NHL, NFL, NBA players get exemptions for testosterone when it drops low enough to where they qualify, because it keeps their career going longer.
Let's get into my favorite topic, which is metabolic health. So just to kind of give a little backstory of why it's my favorite topic now, I did Function Health. Have you heard of that?
Yeah.
And they did all the biomarkers, and my A1C was 5.7. My personality, I'm like, oh my gosh, I'm dying, right? So then I started diving into the whole metabolic health. First, I didn't even know what it was. And then I started really getting rid of all the ultra-processed foods and not eating any added sugar.
What was your fasting insulin?
4.8. So I was right.
I'm doubting that A1C. What was your MCV?
Let me see. I could look it up
Was it
here.
80?
Let's see here.
I assume you also run and jump a lot.
I do.
So yeah,
I play
A1C
basketball.
is often falsely elevated if you run and jump a lot.
I should have talked to you earlier because I've had like 6 months of stress.
Yeah, you got false positive.
I did check it again recently after like 90 days and it went down to 5.6. I don't know if that really matters, but which one did you say?
MCV, it's in your complete blood count, your CBC.
MCV. All right, let's see here. MCV. Well, as I looked that up, is that number that important? Isn't like fasting insulin most important?
Yeah, so the context of all the numbers tells you a lot about your metabolic health, but I would argue one number is not extremely important. For example, people with sickle cell, an A1C is not going to be an accurate marker because A1C is a glycated hemoglobin molecule. So if your hemoglobin lifespan is different due to either, the actual stress of your feet hitting the ground, people in the military used to get this because they'd march and it'd explode their hemoglobin and red blood cells earlier. But, if it's that or if it's a thalassemia or whatever the cause of an A1C being falsely high or falsely low, then that can make a difference. I check a fructosamine in those patients. It's a glycated protein. So instead of looking at the sugar molecule on the hemoglobin, you look at the sugar molecule on a different molecule. But you definitely want, if possible, you figure out, is your A1C, truly high or falsely slightly high? Mm-hmm. And an A1C of 5.7 is pretty good. My rule of thumb is 6 and under is decent. But, what would really tell you definitively is if you did a continuous glucose monitor. I
did do that. Yeah. And it was basically normal for the most part. MCV is 93.4.
Okay.
That's fine.
Yeah.
So then for those who don't even understand, or they don't understand what metabolic health is, a quick definition would be what?
Objectively, a fasting insulin under 7, a normal A1C, if there's not a reason for it to be falsely elevated. In that case, a normal fructosamine. And then CGM data that looks pretty good. The general subjective diagnosis or criteria for good metabolic health is that you don't have transiently high energy in your blood, not just glucose, but also things like triglycerides.
Mm-hmm, mm-hmm. But what about just what is metabolic health? Like, what is that?
Oh, yeah. It's all of your organ systems in the body, including your muscles, even including your brain and your heart, how they partition and burn energy. Are the warehouses overflowing and there's too much? Is there the right amount? Is there too little? And then do you have trouble pushing energy from one system to another?
And why is that important?
Same reason it's important to fill your car with gas. So
our whole body's made up of cells, correct?
Yeah.
And if they're not operating efficiently and effectively, then we're going to have problems. Would you say that all problems are connected back to a metabolic dysfunction of the cell?
They're related to it, but there can, of course, be inflammatory problems. Some people are genetically predisposed to certain conditions. And, that can be the tinder and the spark. And then the metabolic dysfunction is the fuel to the fire of those. But just like a car, there's a reason why if you have a collector car, you go out to your barn and start them every year or two or whatever it is. I'm not sure how often it is. But I know if you have a car for 10 years, 20 years and never run it or don't drive it, then things will rot faster than they would than if you actually use it in a safe way without injuring that machine. Because we are just organic machines at the end of the day.
Mm-hmm. So then how does metabolic health relate to testosterone?
If you have metabolic dysfunction, 2 main things happen. 1, you need more insulin to push nutrients in the cell. And insulin directly decreases SHBG, so you basically metabolize your testosterone and estrogen way too fast. It's arguably it's equally concerning in men and women for different reasons. For men, just because at baseline we're higher risk of heart attacks and strokes. So we're fueling that fire even bigger. And then for women, because they have a more cyclical hormone cycle. And if you're metabolizing it really fast, you have these crazy peaks and crazy troughs, and you don't have any stability. So that leads to peaks and valleys in how you feel as well. The second reason is you're just going to tend to have more body fat. And when you make estrogen, that also shuts down production of actually all hormones. But it includes shutting down production of your testosterone.
Here's a question. So when insulin is present, does that stop the production of testosterone?
No, but it speeds up the metabolism.
Oh, okay.
When estrogen's present, it'll stop the production of testosterone. In fact, when insulin's present, in the adrenals, it usually speeds up the production. It's like if you had a gas tank that's leaking a little bit all the time. You have to continue to put it in, and if you're leaking faster and faster, then at some point you just can't keep up well enough.
Because this is all new to me. I'm trying to learn all this, and from what I understand, correct me if I'm wrong, when insulin's present, when there's a high insulin level, we are unable to burn fat, and we are in now storage mode.
Yeah.
Because then with people who have high fasting insulin levels, they're constantly storing fat because they never have a point where it now drops where then they can get into fat burning mode.
Yeah, it's not unusual to see somebody at the end of their diet, especially if they're pretty lean, with a fasting insulin under 1. And normal starts around 3.
Right.
So people who are really dieting hard, your body is generally pretty good at regaining that insulin sensitivity so you don't become hypoglycemic. That's actually another part of metabolic health, is being able to not become hypoglycemic when you're not eating. If you feel like you're hypoglycemic, even if you're not, and even if you're not eating, it is not a normal thing to feel that. So your body should be able to self-regulate.
What's the symptoms of being hypoglycemic?
Lethargic, lightheaded.
That's low blood
hungry,
sugar.
Wanting to eat. Yeah,
right. That's low
blood sugar.
And you're saying that could be caused by dieting too hard?
It can be, especially if someone does not have great metabolic health. For example, there's a concept called brittle diabetes. And a brittle diabetic is one that has both highs and lows. So they're not good at, they don't have buffer zone for either of those.
It's what's the difference between type 2 and type 1 diabetes?
Yeah, in general, type 1 is autoimmune, and type 1 is basically your pancreas is attacked by your own body, and you do not produce insulin from the beta cell or amylin. That's the two main things the beta cell of the pancreas makes. Type 2 is usually caused by non-autoimmune dietary changes, lack of exercise, too much carbohydrate, too much sugar availability, to where the pancreas is inflamed and overwhelmed due to that. Now, that being said, viruses are probably the trigger for type 1 diabetes. And in a lot of type 2 diabetics, a virus is often the inflammation that pushes them over the edge. So there can be a lot of crossover, and there's a couple types of type 1.5 diabetes, which can be heavily genetic. But type 1 tends to be more genetic and or bad luck, and type 2 tends to be much more lifestyle driven, which means it's more reversible with lifestyle changes.
It seems that this is an epidemic we're dealing with type 2 diabetes, and I feel like people don't even know about it, especially with kids.
Yeah. Most people also don't know they have prediabetes. So prediabetes is pre-type 2 diabetes.
And then how would you know that you have that? Is that fasting insulin?
Fasting insulin can help, but generally you want at least 2 fasting glucoses over 126. You can also look at your CGM data. You can also get a fructosamine. If you had a fructosamine of 300, then you'd have either prediabetes or type 2 diabetes.
What's the fructosamine?
It's kind of like an A1C that does not depend on your red blood cells. So for athletes, often they're better checking fructosamine. But the average person can check an A1C.
A1C is what your blood sugar level on average was over the last 90 days.
If your A1C is 6.5 or above, then it's likely type 2 diabetes. You could also do things like glucose tolerance tests, 1 hour, 2 hours, 3 hours.
You'd fast and then you'd show up and they'd give you the glucose and then they measure to see how much the spike was.
It's what they do in pregnancy because, red blood cells usually live 2 to 4 months. And they probably live more like 2 months. And the average person, they probably live closer to 4 months. And you don't want to be 4 months late on a diagnosis if you're pregnant.
Right. So how would you give yourself type 2 diabetes?
Yeah, the most common reason is lack of exercise, also actually poor sleep and poor diet, high in processed and especially ultra processed foods. And yes, it tends to be high carbohydrate foods, but what matters even more than the carbohydrates is just the straight calories that are consumed.
In general.
Liquid calories also are very high on the glycemic index. So there's something called a glycemic index, and it is a pretty good estimate of if you're pre-diabetic and you eat all high glycemic foods of the same amount of calories, you are probably more likely to become diabetic. That being said, if you have, let's say you have two identical twins, they're both pre-diabetic at the same level, and then you put one of them into a very inflammatory environment, they get sick, they're very stressed, they're not sleeping, and then the other one consumes the exact same amount of calories, but very relaxed. There's not a lot of toxins in his or her environment. Then the one that has a more inflamed pancreas will develop type 2 diabetes earlier. The stronger your pancreas, the longer it is. Like if your pancreas can really pump out insulin, you're probably not going to get type 2 diabetes. You're just going to get obese.
What is that? Just the luck of the draw?
Yeah, and the environmental things that I mentioned.
What are the main ones that we can actually focus on controlling? Because I know water and our environment and all that, but what can we? Microplastics is another one.
Yeah.
But what can we really do about some of these that actually will make a difference?
For most microplastics, you want to sweat them out, and some types of sauna might help to some degree. But you want to sweat them out, and then shower from time to time to wash them off. Would be nice. But in general, to prevent type 2 diabetes, exercise is the most protective thing. So if you look at people who are frequently exercising, both resistance training and cardio, then they're very unlikely to get type 2 diabetes, even if they're overweight. So I do think there's such a thing as someone who's a little bit overweight. And by overweight, I mean high body fat percentage. I don't mean high BMI. My BMI puts me in the overweight category. Exercise is the most protective thing.
But what about the saying, you can't outwork a bad diet?
Yeah, that's also true from a body composition standpoint. So if that same person wants to lose the body fat, then they're going to have to put in work in the kitchen. So
then from what I'm learning, or I've learned over this time now that I'm deep diving in this stuff, it really sounds like it's coming down to added sugar and ultra-processed foods for the diet side. Do you agree with that?
Yeah, and I would add liquid calories to that too. So if someone is trying to lose body fat or be more metabolically healthy, then even the most healthy of fruit blends that you're blending up, try to keep the fiber in the fruits too. But if you're drinking a liquid slurry, Wally style, a huge cup of anything, even if it's your natural stuff, then it's probably not for the best. So, it hurts to see people recommended these nutrient-rich diets with, half and half or, full-fat macadamia milk with, just raw sugar because it's not processed, and then bananas and mangoes and pineapples and, and I'm not against eating those fruits, especially for athletes, fantastic sources of energy, but it's two completely scenarios where you have one relatively low body fat athlete that's trying to fuel and get easy access carbs versus this is the scenario where you're talking about someone who wants to lose body fat.
Or why does ultra processed foods cause type 2 diabetes?
Yeah, mostly just because they're extremely tasty.
Because we eat too much of them.
Yeah.
Interesting.
And of course, many are packaged in plastics and warmed up in plastics. Everyone has plastic in their body to some degree and has for many decades. So, continue to sweat and continue to sauna if you like doing that. But yeah, the main reason is they have ingredients that are hyper refined. So a good example is, it doesn't have to be in a package. Think about the original banana. People can Google the image of what a banana used to look like before it was genetically modified versus the banana now is basically like a candy bar.
Yep.
So think about how hard it would be to actually get the meat of that banana with all those huge seeds in it and that massive peel.
Would you agree with this? We, as an American population, right, we consume carbs as if we were Michael Phelps. But we don't move like Michael Phelps.
Yeah.
Because the carbs is for the fast energy, right? The quick energy.
Yeah.
But if you don't use it, it turns into fat, right? Adipose tissue. And then if you fill that up, then it turns into visceral fat. And then if that fills up, then it turns into liver fat. Is that kind of the process?
Yeah, certainly. And if you're bulking, then I think there is merit to, let's say you're a strong man, world's strongest man competitor, and you say, I have to put on 100 pounds because I'm trying to make money for my family. Kind of a bad spot to be in, but it does happen. Then if you consume higher fructose foods and more high fructose syrup, then you will put on more liver fat than if you didn't. So things like that do make a difference. But at the end of the day, if you think about these two scenarios, pick a very lean cut of meat, like chicken breast, or even a lean cut of steak, and then try to eat as much as you can as that, and then compare it to eating as many croissants and donuts as possible. Yeah. For the average person, they're going to way overconsume the carbs.
But overall, most people should stop eating so much carbs, maybe.
Yeah.
Because we're not going to burn it off.
Yeah, far too many carbs. And I think there's actually merit to nutrient partitioning. So, this is kind of like a little bit similar to intermittent fasting, but around the time of exercise, I think it does make sense to eat enough carbs early enough to replete your glycogen if you're going to be doing high intensity exercise, and even intra-exercise if you're going to be doing that for more than an hour. So if you're running a marathon, then I think you should consider fueling before and during exercise.
Because they're going to use it. But if you're not going to use it, then probably shouldn't consume it. One of the things that I think I've come to realize recently is that you can't tell if somebody's healthy just by looking at them. If somebody's overweight, it doesn't matter, right? Because they could be metabolically healthy. Is that true?
To some degree. If they're obese, then they're not going to be metabolically healthy.
What about like a sumo wrestler?
Yeah.
No?
Probably not. I assume most of them. I'd be interested to see the DEXA scans because, if you look at, I'm more familiar with strongman competitors. I guess I'm friends with several, and, there's obviously weight classes and strongman competitions. But the heaviest of strongmen for the competition, they generally do have to bulk up to 30+% body fat. And a lot of them have very fragile egos because they don't like to hear that because they're athletes. Same thing for offensive linemen playing football. But those people often do have very high insulins and actually low testosterones and high estrogens. And if you do DEXA scan on them or even an MRI to assess actual body fat percentage, it often is over 25% for males and 35% for females, which is my general cutoffs for when body fat is too high.
Where does alcohol come into this equation, and how much does that really affect the metabolic system?
Yeah. Alcohol is a lot of calories, 7 calories per gram of alcohol.
Does your body process it like sugar?
Not exactly. So alcohol's broken down by alcohol dehydrogenase and then acetaldehyde dehydrogenase. But it is broken down actually into more calories per gram than sugar. Sugar is only 4 calories per gram. And alcohol, I guess in the right environment, is very tasty. I don't think most people think actual alcohol is tasty. But the drinks it comes in are usually tasty, or you pretend to like them.
Especially if you've had a couple.
Yeah. So, drinking 15 grams of alcohol is actually more similar calorically to drinking 15 grams of oil than drinking 15 grams of carb drink.
So then would you recommend not drink alcohol?
Yeah. I see the only benefit of alcohol as being social health. So there's some, I guess, cultural component to this where maybe in some cultures, the social detriment of not drinking alcohol is going to make you an outcast in your family and friend group. And in that case, once a month, I think is reasonable. Probably for some people, twice a month, maybe even 3 times a month, but that's pushing it. My rule of thumb is once to twice a month if you don't struggle with alcoholism. But other than that, I actually don't really see a health benefit to drinking alcohol. So if someone's wondering if they should for health reasons, the answer is no.
Because they were saying, and I think they still say, 2 drinks for men per day, 1 for ladies is healthy and fine.
Yeah, I'd say if you look at associations, if a male drinks a very small amount, then they are often healthier than someone who doesn't drink at all, but partly because someone who doesn't drink at all has a lot of health issues. But yeah, I would certainly not recommend drinking daily. For people who do choose to drink, maybe once a week at most, I think is much better. Plus, I'm not totally against alcohol myself personally. In the last couple of years, I have 3 kids, ages 5 and under. So I have not drank hardly at all in the last 5 years. It's just not as fun for me. If I go somewhere with my wife and we're both in the state where we can drink safely, which has not been a lot lately, then, it's kind of fun to experience that together. It's almost like trying a bitter thing or looking at an ugly pig. It's like, oh, this is fun because it's nasty.
All right, let's shift gears a little bit to cardiovascular health. So first off, I do want to make the connection, if there is one, metabolic health to heart health. How are those connected?
Yeah, I mean, most clinics now are just called cardiometabolic clinics because they're so closely intertwined. So, when people do their executive physical at Gillett Health, we just have one of the tracks be the cardiometabolic track. So, completely intertwined. And I would argue very strongly that poor metabolic health is a much higher risk of cardiovascular disease than any lipid particle.
Is that from the spillage of triglycerides out of the fat cells will then get in the bloodstream and start causing wreck?
Partly, although actually diabetes, just high sugar, is going to irritate the lining of arteries, and the lining itself is going to be less healthy. That's a higher risk factor for cardiovascular disease, specifically atherosclerotic disease, which is plaque related, than a high triglyceride level. So yeah, high triglycerides are a risk factor, but the biggest risk factor is diabetes. That's why if you go to a doctor and they diagnose you with diabetes, then the doctor actually gets paid less if we don't start you on a lipid medication, even though diabetes doesn't really have anything to do with lipids, just because lipid medications can decrease heart attacks and strokes, and people with diabetes are at the highest risk of heart attacks and strokes.
So a lipid medication, or what are those called?
There's a bunch of classes. People are most familiar with statins,
right?
But there's also cholesterol absorption inhibitors, PCSK9 inhibitors, PCSK9 protein preventers, and bempedoic acid.
From my understanding, there's not really ever a case that you should be taking a statin or not.
If you've had a heart attack or a stroke, I think you can make a case that taking a statin is going to be much better than not taking a statin. However, I would say people in general shouldn't take a statin just because a certain number, like LDL, is high. So if LDL is high, it requires context. If the person is 20 years old, super lean, no family history of cardiovascular disease, and does not eat many carbs, then that's a well-known phenotype. That's a lean mass hyperresponder, and they shouldn't take a statin just for that. In fact, if there was a better medication and I had to take one, then I would take ezetimibe. So my cholesterol and actually lipoprotein(a) used to be high. ApoB does matter for cardiovascular disease. Okay. It's just a lipid particle, and so does lipoprotein(a). But I don't take a statin, and I will monitor my plaque that's in my coronaries or carotids, because I don't want to die of a heart attack or a stroke.
So you do that with a scan?
Yeah, you can do it with
a CAT scan or CT scan, sorry.
Yeah, not a calcium score though, because I'm far too young. I'd have a calcium score of 0. So calcium score is basically not only worthless, but harmful because it's going to give me false reassurance that I'm okay. So you want something like a CCTA or a carotid ultrasound, or ideally both.
And that checks the calcium buildup in the artery.
It checks the uncalcified plaque buildup.
That will eventually turn into buildup.
Hopefully. Calcified plaque tends to be more stable than uncalcified plaque.
Because right now you go to your primary doctor, get your blood test, lipid panel, LDL is really high. You got to go to a statin.
If you're over 40, yeah.
So then, should we only be caring about the LDL? And you said LDLA, right?
Lipoprotein(a) is a particle unrelated to LDL, and actually a lot of statins make that go higher. But about 20% of people have this genetically high. I have lowered mine from 100 to 20. You want it to be under about 75 or so. And it's just another bad particle that tends to be sticky.
Little a.
Lipoprotein(a).
That's what you lowered?
And ApoB. My ApoB is much lower.
How'd you do
that? Partly from ezetimibe, but also partly from things like nicotinamide riboside, DHEA. There's a lot of things that lower it. Even aspirin can lower it. So we used to debate, should we give people aspirin or should we not? And for the 20% of people that have high lipoprotein(a), some of those respond to aspirin. So there's actually easy ways that you can test to see if you do, and I happen to. So, I'm a better candidate for it than many other people that maybe it just makes them bruise and bleed to where they're going to have more downside. That's why I named my clinic Individualized Medicine, because I don't care about population data. I don't really care about what someone's cholesterol level is. I mean, I care a little bit, but I'm not trying to change the number on the lab. I'm trying to prevent them from having plaque in their heart or plaque that goes to their brain. So we have ways that we can test for this. And there is downsides of doing tests like a CT scan, but it's an easy conversation to have. You can talk about radiation equivalence. You can talk about how many flights between New York and LA that this would equal.
What should the little a be?
Lipoprotein(a) is best under 75 nanomoles per liter, but for some people that have a different risk profile, sometimes just under 100 can be acceptable.
So then if it is high, then you said you'd put them on medication?
Usually more supplements than medication, but I would be more like, if they also had high ApoB, I'd be more likely to add in something like a cholesterol absorption inhibitor. That's usually what I go to first. And
what should the ApoB be?
Depends on the person, but for the average person, 90 or less is ideal. But in the 90s can be acceptable for people who are very metabolically healthy that don't have plaque otherwise. For people who have had a heart attack or a stroke, there's very good evidence that basically the lower the better. And there's not actually downsides of having very low lipid markers like ApoB, but there is downside to medications. So my rule of thumb is under 50 if we can have an acceptable side effect profile of the meds.
How much does red meat affect your lipid panel?
Not that much, unless it's the only source of saturated fat and triglycerides that you're eating.
So like carnivores.
So if you're, red meat doesn't affect it that much if you're already eating a bunch of other types of meat. So if you switch, all of your pork and chicken and lamb and whatnot for beef, it's not going to make that huge of a difference. Or if you just switch pure chicken to pure beef, if you have the same fattiness of the cuts, it's not going to make that huge of a difference. So most people go from eating a bunch of chicken breast to ribeye steaks. So the caloric makeup and the fat ratio of that is completely different. So that'll make a big difference because saturated fat has a direct effect to change how LDL is made and recycled.
So then, does eating more fat from red meat cause your LDL little a to increase?
LDL and ApoB will increase when you have more fat from red meat. Yeah, with lipoprotein(a), it's completely different. In fact, there's some studies that eating more saturated fat actually decreases your LP(a), only a tiny bit, which is kind of bizarre. But for your main, the cholesterol most people think of, LDL, which is actually technically a lipoprotein and not a cholesterol. But anyway, for that most people are familiar with, then eating more fatty meat of any type, it will increase that, especially if you don't consume many carbs, especially if you don't consume enough fiber.
So if you're eating an adequate number of carbs, but you're also eating a lot of saturated fat with meat, it's not as bad.
It's worse for your health, but the number doesn't look as bad.
Because if you're eating more carbs, then it might be affecting your metabolic health, right?
Yeah.
And you're fasting insulin and your glucose.
Correct.
That's interesting. How important is checking your homocysteine level?
I think everyone should do it at least once.
And what is that? What is that level?
Homocysteine is involved in something called the homocysteine methionine cycle, but it's how you give methyl groups to various processes in the body, like your B vitamins, even epigenetic changes involve methylation. But if your homocysteine is very high, then you're not going to activate B vitamins as well for many cellular processes. So it could put you at higher risk of neuropathy. If it's very high, it actually changes your risk of blood clots and increases your chance of cardiovascular disease. So everyone should check homocysteine at least a few times. Even former President Biden had his homocysteine checked on his previous lab panel. Now, he missed a lot of other things in his lab panel in the last couple of years, but he did have a homocysteine checked.
Is there? I think there's like something you should check where there's a ratio from the homocysteine to something else.
Homocysteine to B12 is important, and homocysteine to folate is important. Sometimes we check a methylmalonic acid, and sometimes even an MTHFR. But homocysteine is important in various situations. For example, in pregnancy, it's important for folate activation. But in people who didn't get blood clots, it's important for a different reason.
You talk about the 7 pillars of health. Can you break those down for us and explain why each one matters?
Yeah, these are just lifestyle interventions that are more important for health, including hormone health, by the way, more important than any medication or supplement. And that's your diet, your exercise, your sleep. And then I used alliteration for the rest of them: stress, sunlight, social health, and spirit. So more powerful than any medication or supplement. As far as explanations, diet, exercise, and sleep kind of go without saying. What sunlight means is, don't go bake in the sun until your skin looks like it's very aging. That's just saying that we're in a very unnatural environment. And, I love that we're inside and air conditioning and this and that, but there's a lot of benefits to heat exposure, cold exposure, and even just being outside and even just being able to see green leaves and things that are alive. There's some studies that
just
offices that have windows that are overlooking a park.
Wow.
Yeah, people have much better mental well-being, and so there's a lot of benefits to all of that natural environment. I actually like to go outside, and if you have a dog, you kind of know this. You go outside in the morning, maybe you don't have a shirt on, maybe you don't have shoes on. You get, you feel the ground with your feet, you feel the elements, and I think that kind of helps wake me up, almost like a cold dunk helps wake some people up.
You do those?
I don't do cold dunks. No, I have my outside, the birds, the breeze. I used to longboard, which is basically skateboard. I used to longboard to school and to the hospital when I was a resident. But now I live out in the country, so I wouldn't be able to do it that long. But I'm not against cold dunks. If people do it, they should do it before exercise and not after.
Yeah, I just recently learned that because you actually start stunting the, repairing process maybe?
Yeah.
With the muscles if you work out and then immediately go to a cold dunk.
Correct.
Yeah, but I've been doing cold showers every morning and night.
Yeah.
For me, it's just more of an emotional thing.
Yep.
If I'm feeling down, especially at nighttime, if I get in that cold shower, oh my goodness, I'm so grateful after I'm out. Sleep. So 3 different types of sleep, right? Deep, REM, and then core. Mm-hmm. What are the amounts would you suggest for those?
Yeah. So with amounts, depending on how people are tracking, it's going to look very different.
Apple Watch.
For the average person, so Apple Watch is going to be great for heart rate variability and resting heart rate. But it's difficult to know how much REM sleep you're actually getting because it can't detect the activity of your diaphragm or your brain waves.
It's only heart.
Yeah. So it's great for detecting the heart rate stuff. But, regardless of how much REM your Apple Watch says, you should be getting at least 2 hours per night. And that's mostly later on in a night. So if people wake up at 3 a.m., they might have difficulty getting enough REM. The best way to get deep sleep, which is delta wave sleep, it's kind of the very deeper, relaxing sleep, is just going to bed an hour earlier, because that usually happens very early on. And then a lot of people, when they wake up and they're dreaming, they wake up from REM sleep. So yeah, at least hour and a half of deep and 2 hours of REM would be great, but it's kind of difficult to track. Some people I send to the Wesper website, WSPER, and they do a Wesper sleep program, and they can track it a little bit more accurately.
Yeah, and if somebody is not getting enough, for example, deep, what could they do to improve that? Supplements or diet?
The best way to improve your deep sleep is to go to bed 1 hour earlier, and you will get more deep sleep. Past that, yeah, L-theanine might help a little bit. We know it gives people more alpha waves during the day, which are kind of the calm, cool,
what about glycine?
waves. But maybe, glycine's also kind of an inhibitor or neurotransmitter. So glycine is reasonable. Magnesium glycinate, which is bound to glycine, that's reasonable. And L-theanine is also reasonable. Sometimes people will take inositol, ashwagandha from time to time, but just be careful of not too high of a dose of that.
I couldn't. I tried it and it made me feel weird when I woke up.
Yeah.
It was like I was groggy.
What dose?
I'd have to look it up. It was I think it was Thorne, whatever their standard is, but yeah.
Yeah. The other thing that people can do is eating slightly earlier and not exercising so late. So I tell people 10, 3, 2, 1, 0, 10 hours, no caffeine, 3 hours, no vigorous exercise, 2 hours, no large meals, 1 hour, no bright blue or bright white light. And then ideally 0 variation in the time they go to sleep and 0 snooze in the morning.
Get right up, right? Wake right up whenever the alarm or whenever you're awake.
Yep.
So you said diet, then you said sleep, and then you said
exercise. Yep. We talked about sunlight.
Yep.
We haven't talked about stress yet. Actually, we kind of did talk about stress a little bit with the bench press analogy. You want to be able to adapt to your stress, and 0 stress is not the goal. And metaphysically, I don't think that's why we're put here anyway.
No.
That's the spirit or spiritual aspect. But yeah, I mean, you should be able to adapt to the stressors that life brings you. Call for a spotter if there's something coming up in life that you can see through. But I think that people can progressively overload stress just like they can training, and they can actually learn to enjoy the difficulty of the process. That's kind of the point of sanctification for Christians, but for people who are not Christians, I think that they can also enjoy the grind. Hustle culture, embrace the grind. Yeah. That's just people that are positively adapting with coping mechanisms to stress.
Interesting. How do you train yourself to do that if you don't have Christ?
Yeah.
If I didn't have Christ, you have a different
goal.
I'd be on a couple of antidepressants, to be honest.
Money, status, fame, whatever on the hedonic treadmill drives people to continue seeking and moving. And, some people just particularly like that they're doing something difficult. So I think there's probably ultramarathoners that are like this. Not all of them, but,
is that
just
innate?
Want to say...
Yeah, is that innate,
some people, it can be, but it's mostly learned. So...
Interesting. So if you're not that person who's a grinder who really is looking after or trying to get used to pain and discomfort, you're saying that you can learn that.
You can learn it. In fact, I think most people do learn it. But it's a lot easier too if you have that tendency.
All right. So then what are we missing? Was that all 7?
Social health is another one. There used to be 6. And it was actually Rich Roll. He has a podcast. And he said, because of the pandemic stuff, we got to add social health as a pillar. So I've actually added it since then. And it's pretty self-explanatory. If you're not around people, we're very social creatures. Even if we're introverted and we need our alone time and me time, it's going to negatively affect our health, which I think it kind of happened as a society. And now we're kind of pushing back, and people are exercising more. People are more social again, which I love. And then the last one is just the spiritual health. That's Maslow's hierarchy of needs, which is not perfect, but the classic example is someone who's they've always been an atheist their whole life, and then they get really sick, they go to the hospital, they have a near-death experience, and then they're asking for the chaplain. So most physicians have seen that. Spirituality becomes very important, and people's goal beyond this life. I think it was, I forget, there was a famous celebrity that someone was asking about his legacy. This was a particularly honest person. And they said, well, what do you want your legacy to be? It may have even been Mike Tyson. And he said, well, I'm just going to go to dust, and everyone's going to forget about me in a couple hundred years, and you and pretty much everyone else. So I just want to live the life that I'm meant to, and I don't care about my legacy. And maybe he was being a little bit cynical. Maybe that's just him. He seems pretty legit, but I think that people do need to worry about what happens after. And when you go into a state of very poor physical or mental health, you start to worry about that metaphysical component.
It's the one thing we all eventually have to deal with.
Yeah, everyone is
every
mortal.
single human.
Yeah, even the ones with Neuralink.
Here's my question to kind of wrap this up, specifically with Christians, because I feel that this is prevalent in the body, the Christian body. Okay, it's this mindset of God's got it. I don't have to worry about what I eat. I'm going to eat whatever I want. I'm not going to worry about my health because I know where my eternal destiny is. So whatever happens, happens, and He's got it. What do you think about that?
Yeah, there's certainly an order of priority, and I think that particularly the New Testament is very clear that there is some value to physical training. I think it says this in Timothy, one of the Timothys, but spiritual training is of more importance. But we're obviously supposed to keep our bodies as, temples. We're supposed to keep them clean.
Yeah.
And just like if we were given a car, even if you want to say, yes, physical health is not that important because God is watching over us at the end of the day. And, we could have been born into a condition that is just not compatible with life. Could have been born without a brain, and it happens to people. So it is a gift that we're here, but we are to be good stewards of the organic machines that we have given. Sometimes, frankly, I feel like I am almost similar to a robot that is just put here among the other normal humans, and I'm the only not normal one, but I just happen to look like a human. Because I see things as machines and function and the form of it. Just like you want to keep your house in relatively good condition, you want to keep your car in relatively good condition, at least we can buy another one of those. So at this point, we can't buy another body. Maybe you can buy a prosthetic limb. But people should at very least be good stewards and do the bare minimum.
I think this is very much related to, in Scripture, it talks about the importance of being diligent. So being diligent in really everything in life, but then we don't forget about our own blessing of having a body, right? And also that's related to discipline.
Yeah.
Right? How can you be disciplined in these certain areas like sexual sin and maybe others, but then when it's time to start feeding myself, I just indulge and I just do whatever makes me feel good. And I just kind of turn it off, right? But in my opinion, it's like, if you're going to be disciplined in these areas, you got to be disciplined in every area, because that's what being a Christian is about, and living that life.
Yeah, it's true. And there's obviously a lot of carryover benefits. people who do a lot of physical training, often when you're out on the road, you're just not going to be so aggro. You're not going to be as, you don't have that chip on your shoulder. And even if you're not tired from training, you just don't have that same physical energy like a dog that needed to go to the dog park, but you just kept him at home for a week. That's another benefit to where the rage and the anger and the emotions can be controlled through that physical discipline.
Diet too, right? If you have a poor diet, then for me, this is the most important question for me. Why? Like, why are you focusing on your body? And making sure that it doesn't become an idol. Because I have to make sure, for me, because I get so wrapped up in all this stuff. And for me, it's when I stop reading scripture because I'm trying to research all these other things, now it's probably becoming an idol. But then on the flip side, I try to make sure it's always because I want to glorify God. Sure. I want to serve God. And if I'm feeling super alert and focused and I'm ready to tackle the day, I can now serve God and fulfill His will, which is why I'm focused on it. But I think again, with a lot of, you hear sermons, they don't ever talk about this stuff. They don't ever talk about the gluttony and, all that. Yeah,
it's hard topics to talk about because everyone has their own vices, of course. Everyone struggles with sin. Everyone struggles with body dysmorphia. But I think that people are hesitant to approach it, partly because of the health at any size movement, which there's a little bit of truth to, but health at any body composition is just not true. And, there's a reason why the creation and world that we have, God likes very nice things, like very beautiful and picturesque things. So I think that within reason, tending to our bodies in order to prevent them from, not only becoming unusable, but I think that there is some merit to aesthetic and cosmetic. Pretty much every pastor is going to, trim their hair or shave or do some sort of aesthetic something. So that's a cosmetic procedure, right?
That's right. So what's the difference between cutting your hair and putting down the donut? It's the same thing. Both can definitely, you can hyper obsess about it. Yeah. But I do think people should care about it. Final question here. It seems like you do recommend supplements and maybe vitamins and minerals for your patients. I mean, it seems though that Western doctors or doctors of today will just tell you, oh, you don't need those because you'll just pee them out. So, some things are very difficult to pee out, like fat-soluble vitamins. So some things you need to be careful with, but most people are insufficient in vitamin D. So I recommend checking a vitamin D. People can go to my websites, gillettehealth.com, sagebio.com, and check their vitamin D, even if they're not an active patient. And people can check their CoQ10 level and their carnitine level. But for the average individual, especially if they're an athlete, I think it's reasonable to either get omega-3s in the diet or supplementation, to get your CoQ10 in the diet or supplementation. The more you burn, the more you need. So a lot of athletes can benefit from those supplements. Same thing as creatine, same thing as taurine. And for some people, vitamin B12. For some people, vitamin D, vitamin K2. But there's a lot of supplements that can help support processes. They're no different than medications. They have an effect on the body. They actually have a downside as well. For example, if you take too much vitamin C, your skin can flush. You can want to pee all the time. So I'm certainly pro a lot of those supplements, but I do like it if people will check the level in their blood first. What about a multivitamin? Do you recommend that? I don't think everybody needs a multivitamin, but a lot of people could benefit from it. If my diet is not optimal or if I'm traveling a whole bunch, then a lot of times I will take a multivitamin. They're better in capsules than tablets because they're absorbed better. So people can find more about you, even in Kansas City, or actually you see patients around the world? Yeah, 48 states or so. Yeah, I have 3 other physicians at my practice and 3 nurse practitioners and 2 sports dietitians.
And we see patients that have pretty much any U.S. residence address. But yeah, local patients can come see me here in my clinic in Leawood.
Awesome. GilletteHealth.com.
Yeah.
Make sure you check out his other podcasts. You have your own podcast, which is very informative. You also were on Huberman twice, and then some various other guys too.
Yeah, I've been on a bunch of podcasts. But yeah,
how'd they find you? How'd they find out about you?
They listen to my other podcasts.
Wow.
Yep.
Because I remember I watched the second Huberman one, and he was just sitting there eating it up.
Yeah, we've been friends for quite some time, and I consider him a mentor and a good friend. He's actually the one that told me to start Gillett Health and call it Gillett Health.
Oh, wow.
I was going to call it Sage Health, but yeah, and he convinced me to start the podcast as well. But I think that, podcasters like him can deserve a lot of the credit for improving a lot of people's lives. I think that more people have cut back or stopped their alcohol use due to his episode on that more than probably any other thing in history, which is crazy to think about.
Yeah.
People can just type in my name, Kyle Gillett, in YouTube or Spotify or Apple Podcast, and those podcasts should populate.
Well, it's been an honor that you chose to come on my little tiny show, and thank you so much, sir.
My pleasure.